Guys, if I ever start talking and I'm not recording, please do not like hesitate to jump in and be like, you're not recording. Okay. So I believe a lot of this stuff is going to be review. Obviously, it says review of pharmacology terms. You got it in first semester with fundamentals, I think. They're preparing to teach this type of stuff for the first PN1s right now. Okay, so this is covering chapters 2, 5, and 6. Now, if you haven't looked at your book, take a look at your book. Now, I'm telling you guys, this book is mostly amazing. It's really easy to read. It's straight and to the point. It doesn't get into a whole lot of like detail that you guys as nurses don't need to know. So easy to read. It sounds like a lot, but like chapters 5 and 6 are really short. So it would take you maybe 10 minutes to read both of those chapters. I would highly suggest you read the book. There were a couple students last semester that said they didn't even open the book, which is great because I cover a lot of it on my slides. But definitely if you're a reader and you retain it by reading it and seeing it, definitely take a look at your book. I'm telling you, it's an easy read. It's straight and to the point. Also, don't be afraid if you're confused on something or you don't know the answer, don't be afraid to look in your book or even Google it. Now, you have to be careful with Google. Make sure they're reputable sources, but you can always run it by me too. Just be like, hey, I have this question. This is what Google said. Is it right? You know, no problem. I have no problem doing that. Like I said before, I'm here to facilitate your learning. I'm not here to give you answers. You'll retain it better if you look it up, or if I give you a page in your book. If you open your page and you read it, you're going to retain it better than if I just tell you. Now, I have no problem explaining things. You know, if you're like, hey, I'm confused, but is this right? I have no problems like answering questions, anything like that. But if you're just straight out looking for answers, I'm not necessarily going to give you the answers. I'll give you how to find them. You're going to retain it better that way, I promise you. Drug answer seekers, that's right. Also, I would highly, highly suggest if you are a crammer, you got to get out of that. You've got to get out of that habit. This course, you'll do so much better if you study a little bit each day. I know you've got another course that is pretty busy. You've got a lot of assignments. You've got clinicals. I know you have a lot of crap going on. I totally get it. But if you can shove in 15, 20 minutes of studying time or more if you can every day and just study something with Pharm every single day, it's going to help you a ton. If you're a crammer, number one, you're not going to retain any of the information. So when you're a nurse, you're not going to know. And number two, you're just not going to absorb everything that you need to. Okay, it's like a purge and dump, and it's just not a good idea for Pharm. I'm just telling you that right now. Okay, so review of pharmacology. Oh, guys, I'm going to struggle a lot with these words. I know how to pronounce a lot of them, but some of them I don't. Pharmacology, I do know. I just need to read right. Review of pharmacology terms. So don't feel bad. A lot of these words, these drug names, are hard. Some people feel like it's like you're trying to learn a new language. And so it's hard. So please don't feel bad if I pronounce them wrong. And some drugs are pronounced differently. Some people pronounce like tomato. There's really not a wrong way to pronounce it. You just pronounce it differently. Okay, here's all your learning objectives. You can find them in your syllabus too. They're all right here with each unit. Okay. So we're going to talk about the numbers. So years ago, like even 30 years ago, there were less than 1,000 drugs out there to choose from. Today, over 11,000. And this slide is probably a couple years old, actually. So there's probably over 15,000 by now. There are a ton out there. And like we can't be expected to know everything from every drug. So that's why we have the drug book. There's a lot of drug apps you can get on, WebMD, a lot of different reputable sources that you can find your answers to. Any hospital will have a drug book. Call pharmacists, all that stuff. So we can't be expected to know everything from every drug, but we need to know the basics. So that's pretty much what we're going to learn here now. There's over 10,000 over-the-counter drugs, and that includes like herbs and stuff like that. Okay, so there's a lot, and technology is making it go faster, and we're getting more and more as it goes, right? So we're going to talk about prototype drugs. On the bottom here, so here you have your drug. I don't know if that's even in focus, but here you have your drugs. Some of them have asterisks by them, like aspirin, ibuprofen, celecoxib. They have asterisks. Those are prototype drugs. So what those drugs are, it's pretty much the anyway, I'm not going to try to pronounce that, Megan. I can't right now. Anyway, the prototype drug is like the first drug that came out to treat something, and then a lot of drugs after it are based off of that first one. Okay, so like celecoxib, let's see, what's a better one? Ibuprofen is a prototype drug, and then naproxen kind of goes underneath it. Or morphine is a prototype drug, and then you have meperidine that is based off of it. And so prototype is like the first, it's just like in like a company, like if you're developing something, you have a prototype. That's your first thing, and then you improve on that prototype, right? And you come out with other products based on the prototype. So that's exactly what we're talking about when we say prototype drug. That's the same thing. So now we have drug names. So we have brand names and then generic names. We also have, what do they call them? Pharmacological names, where they're like the chemical value. That's when you have like the dihexychlorothiazide, whatever. And that explains, if you remember back in chemistry, how you can take that name and draw the chemical structure. So they also have those ones. We're not going to learn those ones. We're not going to draw chemical structures. Don't worry about that. But we do need to know, and brand names versus generic names. Brand names here, we're talking about very common drugs. We're Advil, Aleve, Dilaudid. We've probably all heard of those. Generic names: ibuprofen, naproxen, hydromorphone. Those are the generic names. These brand names are owned by companies. The company that makes Advil is owned by that company. You can't just be a drug developer and, make this medication and call it Advil. You don't own that name. They do. But you can develop the same medicine in a pill and call it ibuprofen, because that's a generic name. Nobody owns this name. Notice the brand names are capitalized. Generic names are not. Okay. Everything that we talk about, I'll try to add brand names, especially if they're common, like the ibuprofen versus Advil, or Motrin. Motrin is another brand name of ibuprofen. But anything on the test, anything on the NCLEX, they'll have they'll go by the generic name. Okay. Some medications that very first new come out are under a brand name. They have generic names assigned to them, but the generic might not be developed yet. Does that make sense? Because the company that owns the brand name owns the copyright. I think that's right. What was the copyright to that medication? Until that copyright expires and other companies can make that, will it? Yeah, Braden. Yeah. So yeah, a company, if they develop the medication, a patent, that's the word. Copyright patent, same type of thing. I think it depends. There have been some medications that come out and it only takes a few years and then you'll see generics pop up. Other ones, I'm trying to think. Other ones, they were brand names for years and years and years and years before generics popped up. So 7 is probably about right. But every brand name medication has a generic. Whether that generic's being made under the generic name, that depends on the patent. So, okay, so before we understand all the drugs and what goes along with those drugs and how it affects our body, we need to know how they move through the body. Shelby, yeah, trade name is the same as generic, yeah. I believe so. So we got to know how these drugs move through our body, okay? Also, knowing how they move through our body helps us understand. No, I think, sorry, I'm trying to think. I think the trade name might be the brand. Yeah. I think the trade name is the brand and then generic's just the generic. Yeah. Sorry about that confusion. Okay, so we're going to talk about pharmacokinetics. This should be more, like we said, more of a review. So there's 4 things to go with the kinetics, the movement of drugs through the body. First, we have absorption, distribution, metabolism, excretion. Okay, and depending on the drug, how we give it will affect all of these. Okay, so by knowing how medications are absorbed, how they are distributed, how they're excreted, stuff like that, this will help us understand how it's going to affect your patient. We all know every patient is individualized. They're all different. So knowing these types of things can help you apply it to your patient and how that specific patient is going to be affected. So here we talk about absorption. So route of administration, PO. We all know what PO means, right? My mouth. That is the slowest of all the routes. IV is the fastest. If we give something IV, we're going to get the most immediate results. We give something by mouth, whether it's a pill, a liquid, enteric coated. We're going to talk about those a little bit. By mouth is by far the slowest of all the routes. Okay. If we give it by pill, disintegration of the drug must occur, especially if it's coated. You got to dissolve the coating before you get to the medication, before that's dissolved, and then it has to go through your intestines. Some drugs are absorbed in the stomach. Some drugs aren't absorbed until the colon. You have the first pass effect, which we're going to talk about here in a minute. That's when the drugs go through the liver the first time to be metabolized. You've got lipid soluble versus water soluble. So you've got all those things that interfere with absorption. Okay, what are other routes of administration? Who can name off a few? Okay, IM, intramuscular, transdermal, sublingual, buccal, suppository, IO, topical, extended release, inhalant, sub-Q. intradermal. What about like ocular? There's ocular, nasal, otic, nebulization. We kind of talked about with that inhalant. Now, inhalation and nebulization, they're different. Okay, so yeah, there's a ton of different, they're vaginal drugs, right? Rectal, we talked about suppositories. So there's a whole lot of different ways to give certain medications. PO is the slowest. IV is the fastest. And then all the other ones are in between. Okay, so there are a lot of factors affecting absorption. We kind of talked about, dissolving of the tablet, going through the digestive system, first pass effect, the amount of blood flow we have, right? How's our circulation? The bioavailability of the drug. So that's the percentage of drug available for activity. Some drugs you can't give orally because it's destroyed, so there's no bioavailability. Because our digestive system just destroys all the active drug. So we have no bioavailability. Some, we take a drug like Coumadin, and only 1% of that warfarin or Coumadin that we take, only 1% is bioavailable. So, those are a bunch of factors that affect absorption. Also, the gastric pH, formulation of the drug versus, tablet versus liquid versus extended release, enteric coated, stuff like that. And then our foods that slow gastric emptying, which are like hot foods, high fat foods slow gastric emptying. If we're having acidic foods versus non-acidic foods, how that will increase and decrease our gastric pH. So all of these things affect our absorption. Okay, so now distribution. So this is how it gets from being absorbed. So our body has absorbed it. It's now in the bloodstream. So we're talking about distribution from circulation to the body tissues. Okay, so here we have protein binding sites. So our blood has little proteins in it. Albumin is a protein, so they have all these little proteins. Now what the drugs do is they go in to our circulatory system and they bind to these proteins. Okay. And they're just hooked to them. Now, any drug that's hooked and bound to a protein is not available to get into the tissues. Okay, only drugs that are not binding, they're called free drugs. That's called a free drug. So it's free from being hooked to the protein. Only free drug can get into our tissues and cause a reaction with the receptors. Okay, any drug that is bound cannot. Now, if you take multiple drugs, they can fight over these proteins. So different drugs have different protein binding. I'm sorry, I forgot to tell them something. I forgot to tell you this. I'm interrupting your Analgesics lecture. I have your drug cards to give back to you because I know you'll need them for this class. You can pick them up when you come to do your health assessment this Thursday or Friday. I will be teaching, but they are in an emesis bucket in Renee's office. Don't forget to grab them. You're fine. Okay, so back to protein binding sites. So if you take multiple drugs, they can fight for these proteins to bind to. And some drugs bind better. They're kind of like magnets. You have, I'm sure you guys have shopped for magnets or have magnets on your fridge. Some magnets are really strong magnets. Other magnets are really weak. And they might just, some magnets you can hold 3, 4, 5 pieces of paper stacked on top onto the fridge. And other magnets, you can only do one. If you do more than one, they start sliding down, they fall off. So these are a lot like magnets. The drugs are a lot like magnets to protein. So we have some drugs that are really strong binding, and so they'll kick off the weak binding drugs. And that will cause more free drug. If we have a weak binding drug and we take it with a strong binding drug, then we're going to have a lot more free drug of the weak binding, which then increases side effects, toxicity, all of those things. So kind of important to know any free drug, like we said, will go into the tissues and affect them that way. So highly protein bound drugs means that over 90% of the drug is bound. Okay. Weakly protein bound drugs is less than 10% is bound. Does that make sense? So when you're giving multiple drugs, you need to know if they're compatible to give together, not only because they can cause a reaction to each other, like if you do like IV and they precipitate, that's bad, but they can cause one drug to be more toxic to the body than another. Yeah, Kim, if you have a weakly protein bound drug, you will have more free drug, especially if you're giving it with a strong protein binding drug. So that's a concept that is important to know. Okay, so increased free drug is caused by a couple different things. So 2 or more highly protein bound drugs given together, right? So they're fighting over that protein to hook to, right? Multiple drugs given together. Low plasma protein levels. If you have a patient who has just low protein levels in their blood, there's not going to be enough. Even if they're highly protein bound drugs, there's not going to be enough protein to bind to. So they're going to have a lot more free drug. Okay. Let's see. Okay. So I'm trying to see where I am on my notes. Okay. Plasma protein binding. Stopping or starting a drug that binds to plasma protein changes the levels of other protein bound drugs. And still the same type of concept. If you take them together, or if you stop them, or if you start a new drug, it can mess with those drug levels. Yes, Kim. Yes. So if you have more free drug, it can have an effect on you. So you can possibly overdose. You get maybe your side effects are more pronounced, or where you didn't have side effects, now you do. It can increase, depending on the drug, it can increase your toxicity level. So digoxin's a pretty good one, and antacids, when we get to them, there's a lot of drugs you don't want to give with antacids, a lot of drugs you don't want to give with warfarin or digoxin. And this is one reason why, because of the plasma protein binding. With the digoxin and the warfarin especially, you can affect that. And those 2 drugs are really important. You don't want to get into toxic levels with those drugs because it's life-threatening. So yeah, you get a lot more effects when you have more free drug, because yeah, it's kind of like taking more drug than you need to. Kim, yeah, blood levels will help figure that out. You don't necessarily have to have protein levels drawn every time, but yeah, if it's somebody who naturally has low plasma protein or something like that, they might want to check that. If they're having a hard time with drug levels, keeping them constant, that might be something that they look at, is the protein levels, to see how the binding is with the drugs. Okay, so factors affecting the rate of distribution. So this is whether it's, if you get a quick effect versus a slow effect. Obviously blood flow, right? See how the rate of blood flow to the tissues, If you have some kind of like a peripheral vascular disease, you might, have lower blood flow. It might take longer for the drugs to get to where they need to be. Right? Blood-brain barrier. It blocks 90% of our drugs. So there's a lot of drugs that, the barrier will stop and we can't get through there. So obviously that'll disrupt our distribution. If we're trying to get a drug through there, it needs to be able to get through that barrier, right? And then, like we said before, the protein binding, that will obviously affect our distribution. Yeah, Megan, I would say that it is. I think it's a natural barrier. I think if our barrier wasn't quite as strong as it is, we'd have a lot more like brain diseases and stuff like that. All right, my mouth gets dry when I talk a lot. So yeah, that barrier definitely protects our brain really well to a lot of potential insults. It can be harmful, depending on what you're trying to treat. There are some drugs that cross the blood-brain barrier. Those, like for Parkinson's disease, which I think we're going to learn about in a couple weeks, you're going to want those drugs to cross the blood-brain barrier because it affects our dopamine levels. And so some drugs we want to cross the blood-brain barrier so that we can get the effects that we want. Because with Parkinson's and the drugs that treat that, we need the effect to be in our brain versus in our peripherals. That's where we get the most results, the best results. Okay, so now talking about metabolism. So the drug's been absorbed. It has been, in our circulatory system. It's affected our, whatever responses or receptors that we want it to affect. Now it's going to get metabolized. So this is metabolism is anything that alters, transforms, or changes a drug structure. Most commonly done in the liver. Like 90, probably 95, 98% of all drug metabolism is done in the liver. And that makes sense, right? Your liver cleanses your blood, makes it all nice and clean, gets all the dirty stuff we don't want, all the contaminants out of our system, right? And drugs can be considered as that. So the liver is going to look at that and be like, yeah, you don't belong here. We're going to metabolize you out. We're getting rid of you. Okay. So there's lipid soluble or water soluble. You want to make a note, only water soluble drugs can be peed out, can be excreted. In the liver, a lot of these drugs come into our body's lipid soluble, and the liver will change it to water soluble so that we can excrete it and get it out of our system. Liver is pretty awesome. Take good care of it. You only get one. We don't have a machine like dialysis to keep it going. So it'll change the molecular structure to an entirely different drug. The new drug is called a metabolite. Most of the time, it's inactive, and so it'll inactivate the drug. There are a few drugs that we take that the metabolite, when the liver changes the drug, the metabolite is actually the active drug that we want. I believe when we take, I'm trying to remember. It's an opioid. When we, it's on the tip of my brain. When we take an opioid, it's an inactive drug. The liver actually changes it into the active medication. So sometimes the metabolite is what we want, but most of the time it changes, the liver changes it to an inactive drug form, water soluble, and we'll just excrete it out. Okay, so it's a special, and there's like 50 or so enzymes in the liver that will help metabolize these drugs. Now, there's really one major one. It's this CYP450 enzyme. You don't necessarily need to know that specific enzyme, but that's the one that will change most of the drug, metabolize most of the drugs. Okay. 3/4 of the liver enzymes metabolize endogenous compounds. So those are compounds that our body makes by itself. And then 1/4 of the liver metabolizes the drugs. Okay. Grapefruit. You're going to hear a lot about grapefruit. Not only is it disgusting, but it inhibits the functioning of this CYP450 in like 85%, that should be percent of the drugs. Okay, so there are a lot of drugs. The liver metabolizes the medications. Grapefruit, you're going to hear a lot of that. So keep your ear up for grapefruit, and there are a lot of meds because it affects like 85% of the drugs. So a lot of meds you can't take with grapefruit. So just, stay away from it. It's nasty. Okay. So factors affecting metabolism. So obviously, and are you a grapefruit lover? Pretty much, yeah. It's pretty much just this enzyme. And this enzyme, like I said, there's like 50 of them that will metabolize, but this is the main one, which is why it affects most of the drugs. Grapefruit juice. So grapefruit and grapefruit juice. So obviously, because metabolism affects the liver, is done in the liver, any type of liver function problems are going to affect the metabolism levels of these drugs that happen. So anybody with cirrhosis, hepatitis, cancer of the liver, alcoholics with the cirrhosis, any problems with that. Some people don't have full livers if, depending on their situation. So anything affecting the liver is going to affect the metabolism. The age of the patient, young and old, young versus old. So young kids, when they're really young, like infants, neonates, their liver isn't like necessarily functioning 100%. Like they're still growing. They still, their metabolism isn't quite there. There's a lot of drugs that we can't give infants or neonates because of the metabolism, because of how they metabolize. Now, when they grow up, when we get really old, our metabolism changes also. Those maybe older students, versus like if you think back when you were in high school, like I had a Mountain Dew and a pink cookie every day for lunch in high school. I swear, if I did that now, I'd be like pushing probably 300 or 400 pounds. My metabolism has changed. And so your liver changes as well as you get old. And so older patients, as we talk about here in chapter 6, your metabolism changes. So you need to be aware of that. The nutritional status of the patient, healthy versus unhealthy, obese versus not, if they have like crazy blood levels, stuff like that. And then just plain genetics. We all know genetics just plays a part in metabolism, period. Okay, so metabolism affects the half-life of the drug and the steady state of the drug. So a half-life of a drug, that is the time it takes for the concentration of a drug in the plasma to be reduced by half. So here is a graph that kind of explains it. So say this is ibuprofen, right? You take 400 milligrams of ibuprofen. This is the half-life right here. The first half-life. Now we have multiple half-lives, right? So the first half-life right here looks like this isn't necessarily ibuprofen, but we're going to throw a name on it, right? So you take 400 milligrams of this, 4 hours later in your system, you only have 200, right? 4 hours later, you have half of that. So then that's 100. 4 hours later, you have half of that, which is 50. 4 hours later, you have half of that, which is 25. Okay, so that's how you calculate a half-life. It doesn't go like 400 to 200 and then 200 to 0. Does that make sense? Like every half-life is half of that, and then half of that, and then half of that, and then half of that. So one could argue that the drug never, ever, ever, ever leaves your system. Because, I mean, you get so minute. But, you really, honestly, if you calculate half of half of half of half, you'd never get to 0. But pretty much that's how it works out, right? So a half-life of a drug is when half of it is out of your system. Right, Kimberly, you could get like clear down to near 0. Okay, so a steady state is the amount of drug given equals the amount excreted. Okay, so this is a lot of medications that one would take on a regular basis. We want to reach a steady state. So we want our drug levels to just be like this, right? So we're excreting the same as we're taking. So we take a medication, we take a pill, and we're excreting that much. So our levels just stay at constant. And drugs that you're on for, long term, that is what we want to establish is a steady state. Sometimes it takes a little bit. So you take your first pill and you're down here, then you take a second pill, then you're up here, then you take a third, and then a fourth. And then by the time you take your fourth, you're excreting the same amount as you take your fifth. So now you're at a steady state. Okay, so metabolism affects both of those. If you are metabolizing something very quickly, maybe your half-life isn't quite 4 hours. If you have liver cirrhosis, maybe your half-life on a medication is more like 6 hours. So you're metabolizing it much slower. Okay. Yes, Megan, yes. So we know pretty much with the drugs that we need to have a steady state, and we know how many doses it takes to get up to that steady effective state. Now, some medications need a loading dose. So you'll see this a lot in seizure medications, especially with maybe a very first diagnosis of seizures, right? You have a patient come into the ED, they're having a seizure for the first time, they've been, maybe they're admitted and they have studies done and they're diagnosed with epilepsy or something, right? You're going to be giving them a loading dose. Antibiotics do this too. You'll give a loading dose so this is like if you take a pill. So here you go, you take a pill, you're here, you take another pill, you're here, you take another pill. See, so this is like that, but this could be over 3 hours or it could be over 4 weeks, right? And if you're having epilepsy, if you've been diagnosed with epilepsy, you don't want to wait 4 weeks before you start seeing effects of that drug, right? So you're going to take a loading dose, which is a whole bunch of medication all at once to get you up to that therapeutic level. Some medications you can't do that to, like Librium. Yes, Librium's a good one. Gabapentin is one. Maybe, let's see, depending on your clotting rate, maybe you do that with warfarin to get you, up to where you're not clotting like crazy. So there are some drugs, antibiotic Zosyn, you'll give a loading dose. You'll give a whole bunch of medication over 30 minutes. And then every dose after that is the same medication over 4 hours. So you'll give this loading dose. It'll get you right up into that therapeutic level really fast. And then you continue with maybe a lower dose or less often, but you still stay at that therapeutic level. Okay. So it's a large initial dose to get to that steady state really fast. Some medications, I mean, you don't necessarily need a loading dose. Like I said before, some you can't give a loading dose because it's too dangerous. You could get into toxic levels really fast. Okay, so practice question real quick. Most drugs are metabolized in the liver. That's right. Really important to know. Really easy to remember, but really important to know as well. Okay, the liver. All right, so now we're going to talk about excretion, most commonly done by the kidneys. Now, you can excrete it through your poop, your sweat, your saliva, and breast milk. So some drugs can be excreted that way, but just like the liver, most drugs, I should say, just like the metabolism in the liver, most drugs are excreted by the kidneys. Okay? They filter this water-soluble drug, right? Free drugs and unchanged drugs. Okay, so anything that's lipid soluble, the kidneys aren't going to be able to excrete it, right? Free drugs will go away if they filter it out. Unchanged drugs can be filtered out as long as they're water soluble. Urine pH influences drug excretion, right? Just like gastric pH influences absorption, the pH of the urine influences the excretion of the drug in the kidneys. So just know that some, any type of, not water, anyway, any type of, breast milk, saliva, sweating, poop, you can still get that. Kim, as far as I know, it's the liver has to change the lipid solubles into water solubles. Now, as far as excreted in the GI, there are medications that are useful, but are not absorbed. So, like Go Lightly is one of them, or Miralax, polyethylene glycol, all the same thing. That medication is not ever absorbed by the system. It does work on the GI to get more water into the colon. Anyway, we'll talk about that when we get to GI stuff, but that's never excreted, or that's not ever absorbed through the body, so you don't get excretion through the kidneys that way. So that would be a medication that would be excreted through your GI system. But you can still get it. Also, tear ducts. There are medications that will change the color of your saliva and your tears. And so when we talk about those, they can, and sweating too, there are some drugs that change the color of your sweat so they can dye your clothes and dye your contacts. So we can talk about that. And then we all know that there's some drugs that pass through the breast milk. Yes, Kim, that's my understanding. So to get any of them through the kidneys, they have to be water soluble. Okay, so factors affecting excretion. Obviously, if you have sick kidneys, you're not going to excrete it very well, right? So any type of kidney disease or damage, you can have acute kidney damage or chronic kidney damage. So that will, if you have an acute kidney damage and you're taking meds, you might, your doctor might have to adjust your medication level until your kidneys get back to normal. Now, my father-in-law is in kidney failure, 100%. He's on dialysis. And so he has to be crazy careful with his medications because he can't excrete them anymore through his pee. They have to filter it out through the dialysis. So I have to be really careful. Hydration, any type of bleeding, right? If our circulatory system isn't working right or working too good, if we have, crazy high blood pressure, or if we're hypovolemic, that's all going to affect. Anything that affects the kidneys will affect the filtration, right? So, all right, here is a video. Okay, hold on. I know what's happening. Sorry, I didn't have my link available. Let me know if it echoes. All right, hopefully that kind of explains it in a visual, more for those who are more visual. I try to add videos and pictures and words for all of you. Uh-huh. Yes, Kim, yes. That's completely right. Yes, Megan, that sounds right. Now the free drug will go into the tissues and affect the receptors or what we want it to affect. And then once it's done, it'll come back out. And then, like I said, if it's a lipid soluble drug, it has to go through the metabolism to turn into a water soluble to be excreted. Now, when these free, so these drugs are bound to the proteins. They go through and are metabolized and excreted. So now they're not hooked to the proteins anymore, right? So then the free drug, they can come and hook to the proteins, right? And then they go through the metabolism and are excreted. So then they're taken off the protein. So does that make sense? So that's how when drugs are metabolized and excreted, they're taken off of the protein. So now we have more protein for the free drug to come and hook onto. And that's why you have, that's pretty much why we have to take more and more drugs, because our body just takes them off. Yeah, Kim, just like a taxi. Yeah, like I'm going to take you and now we're going to drop you off and get rid of you. But oh, now I'm going to take another, this free drug here. We're going to hook on. So Stephanie, not necessarily. Some antidotes do act like a protein. They go in and they bind to this extra drug. Narcan works on a receptor level. It blocks the receptor. We're going to talk about that later today. So Narcan blocks receptors, so the drugs coming in to act, they kind of just bounce off. They can't come in and act. Now, there are antidotes that we give for certain drugs that will come in and bind to the drug and make them inactive. So antidotes work different ways. We'll talk about those as we get to them. Stephanie, are you talking about Narcan antidotes? They can't, yeah, some of them, yeah. Some of them go in and block the receptor sites. Some of them bind to the drug and make it inactive. Some of them, what else do they do? Some of them, like vitamin K, like if you have too much warfarin, you're going to give vitamin K, and that acts on the clotting factors of our body and increases the clotting factors in our body to counteract the warfarin. So there's a lot of different ways that the antidotes can work. Various mechanisms. And then there are some drugs that don't have antidotes to them. So, okay, couple of practice questions. So drug A has a higher protein binding affinity than drug B. The nurse would anticipate which drug result in drug B. Okay, so you guys correct. It's A. So the levels of drug B could rise to toxicity. Okay, so when drug A has a higher binding protein affinity than drug B, so drug A is a stronger magnet, right? Drug A, it's higher protein binding. It's a stronger magnet. It's going to kick off drug B, going to give more free drug out there, which is going to potentially cause toxicity, right? So that's what we're going to kind of anticipate that would happen with drug B. Okay. All right. Okay, so we're going to talk about our geriatric friends for a hot minute and then a little bit more when we get to chapter 6. Right now we're still in chapter 2, by the way. Okay, so with our geriatric friends, we talked about metabolism changes, excretion changes. Our liver and kidneys aren't quite what they used to be in our 20s, right? Or teens. So a lower dose of med is usually required, especially with like narcotics and and drugs like that, you're going to want to start slow or start low and go slow. Okay, dose it low and go slow. If you find out that it's not, the low dose isn't working, then go higher. But it's better to start low and go up high than to start high and figure out then that they have a metabolism problem. And then, then they're like in overdose levels, toxicity levels. Okay. They have a higher risk for adverse effects. So extra attention needs to be given to them when giving drugs. And then just ask yourself what physiological changes in the elderly make this happen. We kind of already talked about that. Okay, so labs for liver and kidney function, we kind of are, this should just be a review. So liver function test, you have your ALT, AST, ALP. The ALP is not quite as common as the ALT and AST, okay? And a lot of drug overdoses, they're going to be checking this liver function because if you get too much drug in there and the liver's trying to filter it all out, it's working overtime, so it can damage the liver and make things worse. And then also the kidney function. We need to make sure that the kidneys are working properly so that, they're excreting the drugs properly, that their kidneys are going to work good. No, Kim, they can test the levels. I mean, so they can test the levels of the drug in their system. Once the patient dies and their heart stops beating, the circulation stops. And so it's the circulation through the liver that makes it metabolize. If you don't have any circulation, it's not going to go through the liver. It's not going to metabolize. So everything just kind of freezes. So they can go in and check the levels. I mean, there have been stories of bodies exhumed from years, later, and somehow they test the tissues or whatever, and they can see like the levels of the drugs. So yeah, Kim, it just sits and then you can test the levels of the drugs. Okay, another practice question. Patient has liver and kidney disease. He's given a medication with a half-life of 30 hours. Okay, the nurse suspects the duration of this medication to what? So this is basically saying in a healthy adult, the half-life of this medication is 30 hours. But now you're giving it to a patient that has liver and kidney disease. So the half-life is going to increase, decrease, what do we think? Remain unchanged. Okay, y'all are in agreement. It's definitely going to increase that half-life, right? That filtration excretion is not going to happen like it would in a normal, healthy person. So it's going to increase that half-life. You're going to have that medication in your system a lot longer. Okay, when assessing older adults, those with renal dysfunction, the nurse knows that creatinine clearance is usually right. Decreased, correct. Right? You got your renal dysfunction, it's not functioning, it's not filtrating correctly, so your creatinine clearance is going to go up. Shelby, oh my heck. I totally said that wrong. Your creatinine clearance is going to decrease because you're not filtering it correctly. You guys are correct. I totally said that wrong. The creatinine lab will increase. The lab levels will increase. The creatinine clearance of the filtration will decrease. Wow, I'm so sorry if I confused any of you. Okay. Oh, I'm sorry. And unfortunately, that probably won't be the last time that it happens. Hopefully it is, but it probably won't be. Okay, a patient sustains significant burns to the skin and is experiencing fluid shifts, right, with the edema, with the fluid overload. Nurse would anticipate that this would interfere most with which phase of the pharmacokinetics? So you've got your fluid overload. Okay, correct. It's gonna affect the distribution, right? Fluid overload, that's gonna affect your circulatory system, and this fluid shift, it's gonna affect how the drug gets into the tissues. Okay, so now we're gonna talk about pharmacodynamics. So this is what the drug does to the body. Okay, and there's a few terms to know. Fluid overload can be in the circulatory system, and then the edema is in the tissues. So you have your fluid overload, it's too much, so then it's going to move into the tissues and cause the edema. Okay, so a few terms here, dose-response relationship. So you have your potency. We've all heard of drug potency, right? That's the amount of drug needed to elicit a specific physiologic response. You know, oh, proteins, let's see. Yeah, it could, depending on how severe the burns are, how it's affecting. So just the same as like if you're hypovolemic, it's gonna, or if you're dehydrated, it's gonna affect the distribution. If you're overloaded, it's going to affect the distribution too. Shelby, it definitely could. So yeah, so if the protein levels are altered, it's going to affect your distribution because that is where the protein binding happens, is in the distribution phase. Okay, so you want enough potency of the drug to get a physiologic response, right? If you're having like 0.1 of morphine, that's not going to be potent enough. You're going to need like 4 milligrams. And then maximal efficacy, the point at which increasing a drug's dose no longer increases the therapeutic response. So there are some drugs that, I mean, you'll hit a ceiling where if you take more of the drug, it's not going to do anything else. Some cholesterol meds are like that. You know, you get a certain response and it doesn't matter if you double, triple, quadruple the dose, your wanted response is just going to stay the same. So that's your maximal efficacy. And then therapeutic index is the margin of safety. So you have your therapeutic level, and then you have a toxic level. And your minimal efficacy and your toxic level, and your therapeutic window is like right in the middle. So that's our therapeutic index. I have a slide that will help explain my hand movements. It's the range between the therapeutic dose and a toxic dose, okay? So that is the therapeutic index, and here it is, right here. So some drugs have a large therapeutic index window. Some of them have very narrow. So some medications, it's pretty hard to overdose and get a toxic level. Let's see. Like even ibuprofen or Benadryl, like it takes a lot of medication to get to a toxic level. You got to take a lot of pills. Now, digoxin, Librium, lithium, they all have a very narrow therapeutic index. It does not take much to get from a therapeutic level to a toxic level. So each drug has a different therapeutic window. Now, a low therapeutic index is a narrow. Low and narrow mean the same thing. High and wide mean the same thing. So you're going to see those interchanged. Okay, so pharmacodynamics. We have our onset, our peak, and our duration of action. So our onset is the time it takes for the drug to reach the minimum effect. So when somebody, when you give, pain medication is great for this. When you give pain medicine, they're going to say, how long is this going to take to start working? That's your onset. Now, it's not the peak. The peak is different, but the onset, you're going to say, you know, depending on if it's an oral or IV medication. An IV, say you give IV morphine, you're going to say, you're going to fill it within 3 to 5 minutes, right? Some people are faster than that. Some drugs you can fill right as they're getting into the to the bloodstream, right? If it's oral, you're going to say, well, this is going to take about 30 to 40 minutes before you start feeling the effect of the drug, right? Now, the peak is the point where the drug reaches the highest concentration of the blood. It's going to work the best. So, like morphine only lasts 1 to 2 hours. So their peak time is about 30 to 45 minutes, right? That's where they're going to feel the best effect. And then the drug's going to start tapering off. They're going to start getting in pain again. Their pain's going to grow, right? So that is where the drug reaches the highest concentration of the blood. Now, there are some medications that you're going to draw a peak value, and then a trough value is the lowest drug, or lowest amount, the lowest concentration of drug before the next dose. Does that make sense? So vancomycin is great for a peak and trough level. So you give the medication, half hour later, that's going to be your peak for vanco. Now, when they draw peak and troughs, they're trying to make sure that it's in that therapeutic window. Okay, so this highest concentration of medication, you're going to make sure that we want to make sure that that is in the therapeutic window. It's not too high, it's not too low. We're in this in between, right? And then the trough, they still also need to make sure that the trough level is good. So this measures excretion time, right? How fast it's being excreted, and making sure that we have a minimal amount of drug in there. We want enough drug for our next dose, right? So some medications, they'll draw a peak or a trough, or and. Gentamicin a good one too. Those two probably the most common. You'll get some peak and trough levels with some seizure meds too, if they're trying to figure out. Yeah, so trough is the lowest amount of drug in the blood before the next dose. So you've got, excuse me, so you give the medication, and you know it takes some time for absorption, distribution, stuff like that, right? Depending on absorption, if it's given PO or not. So then peak is about, depending on the medication, it's about a half hour to an hour after you give the drug. So that is going to be the highest concentration of medication in the blood. So that's where you take your peak. Then it's going to start, you know, being metabolized, excreted, but you have another dose coming, right? You're going to give another dose of medication. But before you give that dose, you want to know what this low level is. You're going to draw a trough. And you're going to see what that number is. You're going to draw the trough, give the next dose, which is going to bring it back up again. By knowing the peak and troughs, you'll know if this medication is in the therapeutic range. Okay, does that explain it? I hope that explains it pretty good. But this isn't necessarily something that you'll do with every medication. Like I said, like vancomycin, gentamicin, those are the most common. You'll see those drawn. Okay. And then duration of action, the length of time the drug is expected to give a therapeutic effect. IV morphine, like I said, only lasts 1 to 2 hours. So, you know, when you give a medication, especially with pain medication, it's a good idea to say, okay, this is only going to last about 1 or 2 hours. You know, some medications, it's good to tell the patient, oral medications, oral pain medications last longer. So, you know, if your patient's been getting morphine IV every 2 hours, and now you're changing them over to a PO, it's good to let them know, like, hey, this is going to last longer, because in their head they're going to think, oh, in 2 hours I'm going to need more, right? So just kind of problem solving in the future, like, you know, looking to the future and problem solving. Be like, I'm going to educate my patient that this is going to last longer than the IV, and so at 2 hours they're not going to be like, I need another dose. You know, it's going to last longer. So different forms of medications have longer or shorter duration of action. So if you're giving medications frequently, it's important to know the duration of action so you don't end up overdosing or underdosing even. Underdosing is a problem too. So here's your onset, peak, and duration. And here we can look at the peak and trough too. So like here you give the medication. Here you have your minimal effect, right? Here is your maximum efficacy up here, right? This is your peak level. This is where you're going to draw your level. But now it's going to keep coming down. Look, maybe you have another dose due right here, right at, you know, hour 10 or whatever. So this would be your trough. If you draw it before your next dose, you draw this, then you give the dose, then it's going to come back up again. Does that make sense? So here you can kind of see all of it. Not all of it's labeled, but you can look at it and be like, okay, there's my peak. This might be my trough right here. Or maybe they're trying to figure out the right dose, and down here is your trough. So now they're going to look at the dose of medication and adjust it that way, because maybe they want their trough up here. Does that make sense? So that helps you adjust. That helps the pharmacy and the doctor adjust the medication so that they have the trough at the right level, the peak at the right level, so that we're within this window, this therapeutic range. We're not too high, we're not too low. Okay, so practice question: which nursing actions would be most appropriate for ensuring patient safety with a medication that has a low therapeutic index? Now, low and narrow mean the same thing, right? Kim, I don't know why you have a question mark after every one. You're totally spot on. So yes, monitoring the serum peak and trough levels. That's what you're going to affect with ones that have a low therapeutic index. Okay, so now we're going to talk about receptor theory in the pharmacodynamics area. So receptor theory, it's the analogy that you got to have the right key for the right lock, right? So what are receptors? And where are they? I have the answer to where are they, but what are receptors? Anyone have a guess on what receptors are? Receivers, correct, Kim. They're receivers. So they are very much like the lock here, right? Something comes in and affects them, and then this is, you know, unlocks it or locks it, and then it, you know, continues the wave of action, whether something happens or something doesn't happen with the body, whether we get a physiological response or we don't get a response. So yes, they're receivers. And then depending on what they are receiving, it'll invoke a response or not. Right, proteins, synapses on the membranes, they're on like the cell surfaces of the tissues. They really are just everywhere. Okay, so verbiage you're going to hear a lot are agonists and antagonists. So agonists, also known as boosters, they're going to activate and produce a response. Those are agonists. Antagonists, just like I don't know, I always try to think of it like as an antagonist, like in the movie, like a bad guy, like it's trying to stop, right? The bad guy's trying to stop anything from happening, from, you know, anything good. They're blockers. They're just, you know, causing, not necessarily causing problems, but they block a response. Okay. They prevent receptor activation. So those are antagonists. Okay, so agonists and antagonists. So here we go. So here's your receptor site on the cell, right? And then here we have our natural substances. It's going to come in and do stuff. Well, now we want to take a drug to help this. So now we have our drug, and it's not exactly the same exact thing as our natural substance, right? Our endogenous, whatever this might be, hormone or something. So this is a hormone. It's not the same thing, but it's pretty dang close, and it fits into this receptor, right? And then it's going to cause some kind of reaction. Now here's an antagonist. It's going to block this receptor. So when these come in, and even if the drug tries to come in, that's blocked. That's not going to be able to happen. That's like Narcan. That's what Narcan does. So it'll block it. Sometimes antagonists can come in and kick these off and then block it. So that's a visual on kind of what happens. So they block that reaction. All right, back to kind of receptors. We have a lot of receptors. There's a few that we're really going to talk about a lot. We have our alpha receptors, our alpha 1, alpha 2, and then our betas, beta 1 and beta 2. We're going to learn a lot about those in 2 weeks, September 16th. We're going to learn about those. Our opiate receptors we're going to learn about here in just a minute. Our mu, kappa, and delta. Then we have cholinergic receptors, muscarinic receptors, and then nicotinic receptors, which have nothing to do with nicotine, by the way. Okay, so these are all the most common receptors. We've got histamine receptors too that we're going to talk about. These are the most common receptors that the drugs we talk about are going to be affecting. We have our dopamine receptors. Talk about those too. Okay, then there we go. Dopaminergic ones. We've got our 1 through 5, histamine, the serotonergic, melatonin receptors, hormone receptors, yada, yada, yada. Like we have a bajillion. We have meds that affect every one of them pretty much. So just know they're everywhere. And they can be in different spots too. Like we're going to learn about the mu receptor with the pain. No, just know that there's lots and lots of different receptors. This mu receptor with pain, we have it in our central nervous system. We have it in our gut. These cholinergic receptors we have in our eyes and our uterus for women. And so like we have them in all different areas. And so if we have a drug that affects that receptor, it's going to affect all different areas of our body that we have those receptors. Okay. Okay, so here you're going to see this again, I promise you. Here we have, like, for example, this is epinephrine. It affects 3 different receptors. We have our alpha 1, our beta 1, and our beta 2. So when these receptors get activated, this is what happens. And so when we take this epinephrine drug, we're going to expect an increase in blood pressure because of the alpha 1. We're going to expect an increase in heart rate because it affects beta 1. We're going to affect, know that it will relax bronchioles because it affects beta 2. So by knowing what receptors it affects, we'll know what type of responses to expect. Some drugs only affect one receptor. Yes, it'll relax the bronchioles so they don't constrict. They'll relax, and so it'll keep them dilated more. And we'll get into this a lot more in 2 weeks, very more detailed. Okay, so then we have the non-specific and non-selective. These are a little difficult for even me to keep straight, okay? So we have our non-specific drugs. So these are multiple receptor sites affected by a drug. Okay, so these are like our mu. When I say we have them in our gut, we have them in our central nervous system, we have them in our, different spots. So you take an opioid and it's going to cause respiratory depression. It's going to cause constipation because it's our receptor is in different areas of the body. So it multiple receptor sites. Okay. Now, when we get to non-selective, this is when a drug like epi affects different types of receptors. So it'll affect multiple receptors, different types of receptors. Okay. And those different types of receptors are going to be in multiple sites as well. Okay. So non-selective, they're not selective on any one receptor. They're going to affect multiple receptors in multiple sites. They're non-selective. They don't care. Non-specific, I know that seems a little, I mean, they should be specific, right? Because they only do one receptor in multiple sites, but just, it's a little confusing with the wording, but this should help explain it. So non-specific, yes, same receptor, different locations. Non-selective would be different types and different locations. Yes, Kim, yes, you've got that correct. So, like I say, it's even a little, because this non-specific gets me every time. It's a little confusing for even me, but just know multiple receptor sites, one receptor, same type of receptor, right? Multiple sites. Different receptors, also multiple sites. Like Kim said, it's just more vast. The non-selective is just more receptors and more sites. You're going to get more of a drug effect. Okay. Overall broad mechanisms of drug actions. Okay, so a lot of our drugs, you need to know the mechanism of action. Okay, so there's a lot of different ways that they can act on, right? So they can stimulate, enhance what the body can already do. So maybe an anti-inflammatory kind of stimulates, a hormone, anything that will like stimulate your thyroid, stuff like that. So it's what the body can do, but we're stimulating it. We're pushing it a little bit more. Depress, it decreases an activity or body function. So any type of depressants, we have depressants, we have stimulants, right? Depressants. And then we have irritants. It irritates or produces a noxious effect. So we do take medications to irritate, produce a noxious effect. Replacement, that's more of like estrogens or testosterones, hormone replacements. Then we have cytotoxics, kills invading parasites or cancers for all you oncology nurses. And then we have our antimicrobial, prevent, inhibit, or kill infectious organisms, and they do that multiple ways. So antimicrobials will have more lists under that one because they prevent, inhibit, and kill in a lot of different ways. And then immune modifiers, enhance, change, or depress the immune status. So immunosuppressants, stuff like that would be under there. So these are broad, like this says, broad mechanisms of actions that you're gonna learn. Okay, side effects. So all drugs have side effects. They all do. Even at the correct dose, they all have side effects. Some of them are felt, some of them aren't felt. They're usually predictable. We know that this medication is probably going to, we know opioids cause respiratory depression. We know that. How much respiratory depression? That obviously is, has a lot of factors into that. But we know that it's going to cause some kind of respiratory depression. It's predictable. Okay. They range from inconvenient to severe. So, opioids, they can have a little bit, like our patients might need a little bit of oxygen, especially when they sleep because they're not breathing quite as fast and as deep, right? Or severe. It could cause some severe respiratory depression where you're giving rescue breaths because it can be bad. Rashes. Some medications cause rashes. It can just be like a tiny rash, or it could be like hives all over the freaking body. Okay, it's one of the major reasons for patient noncompliance is they don't like the side effects. There's like hormone replacement that can cause some flushing, some like what do they call them, like the heat waves. I'm at a loss for words. I do this a lot. I get at a loss for words. I blame it on graveyard shifts. Hot flashes. Thanks, Olivia. They get hot flashes, stuff like that. That can happen without and with hormone replacement. Maybe their hot flashes get worse with hormone replacement. And so they're like, yeah, like I thought it was bad before. It's really bad now. This isn't going to work. Or maybe, so a lot of the side effects, it's a major reason for patients not to be compliant with their meds because they just can't handle it. So nurse education is vital with side effects. If you're sending home patients on certain medications, like it's really important for them to know, hey, your child is going home on some antibiotics. It's going to be a 14-day course. Antibiotics can cause diarrhea. So that's an expected thing. If your child gets diarrhea, it's expected. If not, and you get those overprotective, crazy parents, I shouldn't say crazy because diarrhea is kind of important to keep an eye on. But, you're going to get a call back and be like, my daughter was just in the hospital. We've been home for 3 days and now she's got this massive case of diarrhea. Where if you tell them, like, this is an expected side effect, like we're expecting this, you should expect it. If you don't get it, great. But if you do, it's expected. Then when that parent changes the diaper or, talks to the kid and they're like, yeah, I've got diarrhea, they can be like, they said that would happen. So then you don't get the panic, oh my gosh, they have diarrhea now. No, go back to the ED. So it saves you heartache, saves parents heartache. Just side effects are vital and essential with education with meds. Now, adverse effects. These are different, and side effects and adverse effects are used interchangeably. So just know what the definitions are, but also know that they are used interchangeably in the hospital, the clinics, even in your books. So just understand. So adverse effects can be mild, severe, or life-threatening. So very similar to side effects, but the life-threatening part, that's the big thing with the adverse effects. These are unintentional, unexpected reactions. You can get, a rash of patients taking meds and they get a rash. Well, maybe that's not one of the side effects that is expected with this med. It's unexpected. So it would be considered an adverse effect. Now, a rash isn't life-threatening, but when you get anaphylaxis, that's an adverse effect. Obviously, anaphylaxis is an unintentional, unexpected, unwanted effect of this medication. Okay? It can occur after the first dose, after a few doses, after several doses. You could take amoxicillin, once every year, and in 6 years, you all of a sudden have an adverse effect. It can happen anytime. They're always undesirable. Sometimes we give medications for the side effect. We want the side effect. Benadryl is a good one. One of the side effects is drowsiness. Who's ever taken Tylenol PM? Anyone? That's okay. You don't have to speak up. But if anyone has taken Tylenol PM, that PM is Benadryl. And you're not taking it for being a histamine blocker, right? You're not taking it for your allergies. Oh, maybe you are. Maybe you get allergies at night. Most people don't, though. One of the side effects of Benadryl is drowsiness. And so we want that side effect to help us. Does that make sense? We're not taking it for the antihistamine. We're taking it for the drowsiness. That's a wanted effect. So some meds we take because we want that side effect. These adverse effects are undesirable. We don't want them. Okay? We're not taking the med for the side effect. It's an adverse effect. It occurs at normal drug doses, so this doesn't include toxicity levels, okay? And then it represents variances from planned therapy. So it's basically what that's saying is it's like we have this planned therapy, something has happened, you have some kind of adverse effect, and now we're going to change that therapy, okay? So people who have a change in therapy, an adverse effect can be a reason for that, or a change in drug or something like that. It could be because of an adverse effect. So know what the definitions are with side effect versus adverse effect, but also understand that they are and can be used interchangeably. Okay. All right, we have these black box warnings that you're going to see. Some medications have them. These are life-threatening effects. So there are some black box warnings that say that they increase suicidal ideations in people. I believe cigarettes have a black box warning on them. Accutane has a black box warning because it will cause, it's a teratogenic, right? Anyway, it is really bad for fetuses. So black box warning, life-threatening effects that can happen from taking medication. Idiosyncratic response is an opposite reaction to what was anticipated. A good example is Miss Rachel. She was going on, our teacher, Rachel, she was going on a trip and gave her girls Benadryl to help sleep on the plane. Well, guess what? One of her girls had an idiosyncratic response. So this girl did not sleep. It wired her. It was an unanticipated response. So it's an opposite of what you want. Kim, does that happen to you? Or or is that a late response? I don't know. Sometimes I can't keep up with, the Tylenol PM. That's right. So it's an opposite reaction of what was anticipated. Okay. So Benadryl is a great example of that. You anticipate, maybe you're going on a long flight and you're like, I'm just going to give, don't give it to babies, but, maybe your toddler, a little dose of Benadryl to help fall asleep, and it doesn't work and it wires them. About 5 to 10% of the population that happens to, by the way, with Benadryl. And then we have tolerance. Tolerance is when the body gets used to the drug. And so increased doses of the drug are needed to get that same therapeutic effect than they had before. So opioids are a great example of this. Maybe you started with 5 milligrams of Lortab or hydrocodone and you took that for 3 months. Well, now that 5 is not working. Your body's getting used to it. So now you have to go up to 7.5. You're on that for a while. Then you get up to 10. And so that's where a lot of these drug users get in trouble and get caught because they need more and more and more of the drug because their body is building up tolerance. They're getting used to it. Okay. So pharmacogenetics, so genetic factors that influence the individual's response to a drug. Okay. So we've got tolerance that we just talked about. It's, your body's getting used to it. It's getting a decreased response. Because it's just like, we know we need more to get a normal response. So we've got tolerance, the placebo effect, which is real. It's a real thing. It's amazing. This is a physiological drug response, not attributed to the chemical properties of the drug. It's all psychological. You can tell, a kid, you can tell an adult this too. Like if you give a med and say, okay, this is going to help with your headache, this is going to help with your nausea, this is going to help with whatever it is, they're going to think, oh, I'm taking this drug and it's going to help me. And they're going to believe it and it's going to work. So not always does it work, but the placebo effect is, see, Amy, you exactly. Now my son has, I forget what it's called. It's a mild case of it, but he gets sick whenever he, like physically sick whenever he gets excited, nervous, or anxious. He gets sick, like like to the point where he's throwing up, like crazy sick, throwing up. So my in-laws took him on a trip. Him and his brother took him to like an overnight trip, and he obviously was like excited about this trip, right? And he was like, I'm nauseous, I don't feel good, like his stomach will hurt really bad. He'll get really nauseous, like, I mean, physically ill. He's thrown up every first day of school. He's getting better though. He didn't throw up this year, but it used to be really bad, and his neck was really sensitive. Anyway, so my in-laws stopped and got meclizine because they were thinking that he was sick because of the car ride. So they stopped and got meclizine, gave him some meclizine, said, here, this will help you feel better. So guess what? Every car ride for weeks, he's like, I need my medicine, and it helps, and it's, so, I mean, that does have some kind of an effect, but it's not like he wasn't getting car sick. It wasn't because he was dizzy. It was for a different reason, but he honestly thought that stuff kept him from getting sick in the car. So that took a while for him to get off of that. But that's a type of placebo effect because they gave medicine saying, hey, this is going to work. And it did for him. Yeah, whatever helps, whatever does it. I mean, it was kind of sad because he'd get really sick and like throw up. They'd take him birthday shopping, and he'd get really sick and throw up, and they'd bring him home and be like, he's sick, he can't. And I'm like, he's not sick. He's anxious. He's making himself sick. It's a lot better now, though. It was pretty bad before. Let's see. So pharmacotherapy, use of drugs for the purpose of disease prevention and treatment. Okay. So we have our therapeutic classification. So that's what benefit the drug produces. So a therapeutic classification for an opioid is pain relief, right? Antihypertensive. Those would be therapeutic classes. Pharmacological classes, on a physiological level, what the drug does to produce its therapeutic effect. So a pharmacological classification would be an opioid, or where a therapeutic class was antihypertensive, the pharmacological classification would be a beta blocker. So therapeutic is how it helps, what it does to benefit. The pharmacological is more on a physiological level on how the drug works. It's a beta blocker. It's a calcium channel blocker. It's an antiviral. It's an antibiotic. It's a, stuff like that, how it works on a pharmacological more of a level. Okay, and then we have off-label uses, which we're going to talk about because a lot of drugs have off-label uses. So what an off-label use is a non-approved FDA use of a drug. For example, Benadryl. Off-label use is as a sleep aid. I believe that's an off-label use. Maybe they market it as a sleep aid. I'm trying to think. I don't take it on a regular basis. An off-label use of, let's see, I'm trying to think. I can't think of anything right now. Basically, it's an effect that a drug has that is not approved by the FDA to take that drug. Okay, but it works. So, for example, I was in labor with my first child, and it was not progressing, and I was in labor for hours and hours and hours and hours and Hours, yeah, Braden, exactly. Adderall for weight loss. That's an off-label use. I don't know of a doctor that would necessarily prescribe it for weight loss, but yes. Now, Megan, some of those are called adjunct therapies. So there are some antidepressants that are FDA approved for anxiety. So there are some that are FDA approved. Off-label use is just stuff that's not approved by FDA. But anyway, so I had my labor wasn't progressing, and the doctor came in and said, "Hey, I want to try this medication on you. It, it helps progress the labor, but I'm using it off-label. It's not FDA approved for this reason, but it works." And I, for all those who've been pregnant, at that point, I was like, whatever it takes, dude, whatever it takes. So I actually had to sign waivers at that point because they were using it for an off-label use reason. I had to sign waivers for them to use it. And they didn't end up using it. It actually worked out. But sometimes you do have to do that. So yeah, Megan, that could be off-label use for cholesterol medication. that's what atorvastatin is cholesterol medication. But yeah, like sometimes propranolol is a beta blocker for blood pressure. They use that a lot for headaches and migraines. So that's what off-label use is. And a lot of medications have off-label use, and we'll be talking about those. This got cut off. Why did it get cut off? Let me figure out what it says. Because it cut, okay. So it works for a specific purpose, not related to the drug classification. So, yeah, Kimberly, that's another good way to put it. That the side effect of a drug benefits you in a different way that the drug's actual intention is, that was approved by the FDA. Yeah. So that's an off-label use. It's just not approved by the FDA. But it works. Okay, drug-drug interactions. So drug-drug interactions can happen at the absorption level, right? When two drugs are taken concurrently, one drug can change the pH of the gastric acid, and it'll affect the absorption of the other drug. It can affect it at a metabolism level. It can increase or decrease the rate of metabolism. And also the distribution level is not on there, but we talked about the distribution level with the protein binding, right? So it can affect that as well. And then the excretion, some drugs can increase and decrease renal excretion. So drug-drug interactions, if they're incompatible with each other, it can be on like an absorption level or a distribution level or a metabolism level or excretion level. So any of those. And then also with the metabolism and excretion and absorption stuff, that can kind of, some drugs are better taken during the day versus at night because most people sleep at night. So their absorption and metabolism might change. And so so there's a lot that goes into figuring out drugs and what they do to each other in the body. Okay, so here's the distribution side, the competition for protein binding sites. So we talked about that, right? And we talked about what the result is with that, depending on the high protein and weak protein binding. Okay. So with the drug-drug interactions, we can have a couple of different effects. We can have an additive effect. Additive, think of it as 1 + 1 = 2. So it's when two drugs with similar actions that are given together and the clinical response is greater than that of either drug given alone. So this is a great example, hydrocodone with acetaminophen. We've got two pain relievers, Okay, and together they're going to relieve the pain better than just hydrocodone or just acetaminophen. Okay, so you put them together, you get a greater response with the two of them together, right? The synergistic effect is when two drugs are given together and their combined effects is a lot greater than what you want it to be. Okay, so this is more of a 1 + 1 = 3. So that here you have your hydrocodone with your alcohol, right? So you with the hydrocodone you have respiratory depression, CNS depression with the alcohol. You also get that, but together it's not just a 1 + 1 = 2, it's a 1 + 1 = 3. So together you're going to have a much greater effect than either of those together, but it's like more than an additive effect. Okay, that's when it gets a little out of control, a little out of hand. Okay, and then we have our antagonist effect. When two drugs given, one drug reduces, blocks, or reverses the other effect of the drug. It can be wanted, like with the Narcan, and if you have an opioid effect or opioid overdose or something, and you give the Narcan, the antagonist effect might be wanted. You want that, right? Other times it might not be wanted. You don't want anything to affect your digoxin levels because you have a very, very narrow therapeutic window. Your lithium, very narrow therapeutic window. So you got to be careful because you don't want to have an antagonist effect where it reduces, blocks, or reverses the effect of the other. Okay, so how can we minimize drug-to-drug interactions? Does anyone have any idea? Right, know what drugs affect what drugs. Give it different times, right, Amy? So if you know that these two drugs affect each other, give them at different times, right? You don't want to be giving your morphine and hydrocodone together. That's bad. Or maybe, right, Braden, correct. Minimize the size of the med list as much as possible, right? If you have a person on 12 different meds, is there a way that we can decrease that, right? Maybe, get a different drug that does two of the same things as two other drugs. So now we're taking two drugs and trading it for one. So yeah. And unfortunately, you get into those older people, like we'll talk about here in a second, and they're taking drugs to counteract the side effects of other drugs. So that's how we grow these drug lists, is you're like, oh, this is causing my blood pressure to go high, so let's get a blood pressure med to decrease that. Oh, but now this blood pressure med is causing this problem, so let's give this med to counteract this problem. And right, polypharmacy. Right, decrease the polypharmacy. How about sticking with one doctor? Right, knowing the half-lives. Yeah, they have a longer half-life. Give the medication later or give it sooner. Yeah. Yeah, and like I said, sticking with one doctor. If you're going to 7 different specialists and they can't see, you know what I mean? Like they might not know that this doctor just put you on a blood pressure med. And so now for whatever reason, they're going to put you on a blood pressure med. So now you have 2 blood pressure meds together and they don't, one doesn't know about the other. And so, yeah, having the doctors collaborate, keeping your med list up to date. If this doctor just started you on something, you need to let your other doctors know. Or if they took you off of something, let your other doctors know. So yeah, definitely keeping your med list up to date and being transparent with your doctors. And asking questions. On the other side, if you are a doctor, or in our case, nurses, asking questions. Like what meds are you on? What doctors are you seeing? Even depending on the situation, even say, hey, does your renal doctor know that your cardiac doctor just gave you blood pressure meds? Oh, no, I didn't even think, because non-medical people don't necessarily correlate those things. Does that make sense? They don't correlate. The heart and the kidneys work together to figure out our blood pressure. They're thinking, oh, the heart's blood pressure. The kidneys are peeing, like they don't have anything to do with each other. And so they don't correlate that like we would, obviously. Understand that the heart and the kidneys work together. And so anything affecting the heart is going to affect the kidneys to a point. And so they just don't think that way. They don't know to think that way. And so, you know, we need to be actively thinking that way for them. Okay. Okay, real quick, we're almost done with this and then we'll go to lunch before we hit our pediatric ones, before we hit chapter 5 and 6, which are short, by the way. Okay, drug-food interactions. So like we talked about before, foods can mess up our absorption levels, right? Iron supplements and vitamin C, if taken together, they decrease the drug absorption, okay? So if you're taking iron, don't take it with vitamin C. Don't take iron with milk. Don't take iron with anything with vitamin C in it because it'll bind to that iron. It's not going to do any good. Okay. No, I wasn't thinking. I was thinking calcium. Sorry. Iron with calcium. Don't want to get those two together. Vitamin C, and iron and vitamin C increases the drug absorption. Sorry. Let me fully read that through. A full stomach or greasy, fatty dairy food can decrease some drug absorption. Some drugs are required to be taken with food. Other drugs you don't want to take them with food. It can alter their absorptions. Okay. Metabolism. Here we go with the grapefruit. I should get like a jingle every time I talk about grapefruit. I should play the jingle because it's going to be often. Okay, it inhibits the drug metabolism with that CYP450 enzyme. Okay, that's right. It's going to inhibit that enzyme, which inhibits the metabolism of the drug. Okay. And then it can result in drug toxicity. So, is this drug? That's right. Every time you hear the jingle, you'll be like, grapefruit. So, is this med okay to take with grapefruit? A lot of elderly people, especially I noticed this working in the care center for the little amount of time that I did, a lot of older people like grapefruit. I don't understand it. I think it's nasty, but maybe my that's right. Me neither, Brayden. Grapefruit, I'm just like, get that away from me. Maybe my taste buds will change by then. But anyway, so good to know. You know, if they're taking a statin, hey, do you eat grapefruit? Because you can't have grapefruit with these. Okay, and then drug-induced photosensitivity. There's a lot of drugs that change the way your skin reacts to sunlight. Antibiotics are a good one. You're going to sunburn a lot more. There are a lot of drugs that increase the photosensitivity of your skin. So, obviously, prevention is to use sunscreen, long sleeve clothing, avoid sunlight, direct sunlight to help combat that photosensitivity. And then it's good, obviously, with all these teaching with the side effects and stuff, it's good to tell your patient this. Hey, you're on a sulfa drug. You're going to burn a heck of a lot easier. So you need to be careful when you're out in the sunlight. And then, you know, they're not surprised when they go out for 15 minutes and have these major sunburns. Okay. So that is the end of chapter 2. Do you guys have any questions about pharmacokinetics, pharmacodynamics? I don't think so. No, there's interactions between Accutane and Bactrim. The sulfa with Bactrim, sulfa is a good one. There's a lot of medications that cause photosensitivity, and so I just know sulfa with the with Bactrim I know that one's a good solid one that causes increased sensitivity. It just, yeah. So Accutane would be one of those drugs that causes photosensitivity. So, Kim, one reason why, especially being female, is that it is a huge teratogenic medication. Like, yeah, it's category like X. Is there a category X? Like, to get on Accutane, you have to have a pregnancy test, and you have to have, it's one of those meds where every month you have to have a pregnancy test, a new prescription from the doctor. Like, it's so, yeah, it's very, there are a lot of teratogenic medications out there, but this one's like number one. Yeah, so they're gonna try creams and ointments and other pills and stuff like that, like before they get to that Accutane. Because if you get accidentally pregnant on that, that's, you're gonna have, like, best case scenario. I don't know if it's best case scenario. I don't know how to categorize it, but from a miscarriage up to incredible birth defects. Kimmy, if your doctor might want to change doctors, maybe. Some doctors are more liberal than others. So anyway, I just know that's a dangerous one, and some doctors are like, staying away from it with a 10-foot pole, where others are like, oh, like, as long as you have a pregnancy test, we're good. You know what I mean? My OBGYN was so into natural family planning that he wouldn't ever he wouldn't even prescribe birth control, any form of birth control. And so if any of his patients wanted birth control, he had to get one of his colleagues to prescribe it because he wouldn't. So some doctors are, more liberal than others. So you might want to consider changing doctors. Or if you're seeing like a GP, maybe go see a dermatologist instead. Anyway, options. Okay, do you want a half hour? How long do you guys want your break? Your lunch break. And then we'll go through chapter 5 and 6 rather quickly. I'll try to do it quickly. I'm a pediatric nurse, so I'm trying to, I'll try to keep it quick. Okay, so we'll come back at 1:15 and then finish up. Sounds good. Record. So, chapter 5, pediatric considerations with medications. So with pediatrics, there's limited research because who wants to do research on kids, right? If something goes wrong, that can be detrimental. There's been problems with obtaining informed consent because, do you want your kid to be a guinea pig? Most parents don't. Different drug labeling and dosing instructions. So they did pass a Pediatric Research Equity Act in 2012, which encouraged more pediatric pharmacology research so that that would go forward a little bit. So they have different ways of doing that now, especially with technology. And a lot of the new drugs require studies in pediatrics for the drug use. We kind of talked about this a little bit with the pediatric pharmacokinetics, with the absorption, maturation of the GI tract. Everything's still just kind of developing. And so their absorption, their distribution, their metabolism, their excretion is all going to be different just because they're not fully done maturing and growing. So nursing implications. So pediatric drug dosing and monitoring is going to be a little bit different than dosing and monitoring adults. So you want to monitor for therapeutic effects because the dosing is going to be different. Any adverse reactions, sometimes they're a little more sensitive or maybe not as sensitive, kind of depending on the medication and what they're doing. Calculations, the dose is per kilogram. All pediatric drug doses are weight-based. It's all based on weight. They really don't care about age. They just care about the weight of the child. Age plays a little bit of a part in it, but mostly it's, if you're going to calculate a dose, it's going to be weight-based, based on the kilogram. And then when administering the medication to pediatrics, you got to consider their developmental level, cognition level, their differences, maintaining safety while ensuring comfort, and then family-centered care. A lot of those who've worked with kids, if you give the medication to them yourself, they're not going to like it. They might fight you. But if you have their parents give it to them, maybe they're a lot more willing to take it. So that definitely plays a part in it as well. Let's see. Okay, so teaching needs to be directed toward the family and caregivers and the patients depending on the age. I mean, obviously you're not going to be giving infants teaching or even toddlers necessarily drug teaching. That will be directed towards the family. But if they're, you know, old enough, little older than toddlers on up to teenagers, I mean, you know, you can definitely teach them. I mean, you can explain to a 4, 5, 6-year-old that, you know, this medication doesn't taste good, but this is what we're going to do to help that so that you can take this medicine. And they can, you know, understand that, okay, it's not going to taste good, but I need to have it. You know, it's going to help me. And each child is different. Some kids, so my youngest is gung-ho about taking medicine. Like, she wants medicine, and when she refuses it, I'm shocked. But there are other kids who, I mean, it doesn't matter what you do, no amount of bribery or anything like that is going to get any of this med down this child. So I mean, each kid is completely and utterly different. You need to consider their level of knowledge, developmental age, and that's not just their, obviously not just their physical age, but their developmental age as well. If they're developmentally delayed, that will play a role in it. And that's how it is with any age, really. Their cultural factors, anxiety levels. I mean, some of you maybe were hospitalized as children, and maybe you have a fear of hospitals, or maybe not. Maybe you're comfortable in them. Like, it all just really depends on the person, their experiences. And then communicating with pediatric patients and families, always get down on their, you know, down to their level. If you're talking to a child, get down onto their level. Don't just stand over them and talk to them. Also, one thing I failed to mention, and I don't have it written down here, but so the drug calculations are dose per kilogram. The urine output, and you should get this in pediatrics too, but the urine output is mils per kg per hour, up to 30 grams, because then that's 30 mils per hour, right? And that's an adult level. So just to remind you of that, I guess. Drug administration. The oral form of administration is always the number one choice because it's less traumatic. It's very traumatic for kids to get an IV. Working on pediatrics, we restrain children quite often when placing IVs. We wrap them in blankets, we lay on top of them, we have to It usually takes more than 2 of us. Sometimes 3 or 4 of us nurses have to go in and hold this kid down to start an IV. So if you can give a medication orally without having to start an IV, that's going to be the best for the child and for you. Less traumatic. Sometimes it's unavoidable. That's just how it is. But there's subcutaneous, intramuscular, intravenous medications. Let's see. Decreasing pain and anxiety is huge. So teaching them, don't ever lie to a child. If you're going to give a shot and they say, oh, it's going to hurt, it's going to hurt, and you say, oh, no, it's not going to hurt. That is the fastest way to lose all trust forever with a child. And it can not only ruin trust with you and that child, but medical workers in general. So teaching, letting them know exactly what is it going to be, what they can expect, even if it's unpleasant, just so when it happens, they're not surprised. That is the worst. So intravenous sites, the hand is the most preferred. They're easier to see. It's just the best. For those who haven't been in the pediatric unit yet, haven't seen IVs being placed, depending on the child, of course, we do it in the dark with, if any of you guys have ever played with a flashlight and like put it up against your hand and then you see, the red glow and you can see your veins, that's exactly what we do. We put a bright light underneath and we look at their veins, and that's how we start an IV, is in the dark with a bright light under their hand. And the first time I saw it and the first time I did it, believe you me, it was scary. But you get used to it, and it's just the easiest way, and you're less likely to miss a vein that way. So honesty, you want to definitely show them respect. It doesn't matter what age they are. You need to respect them and their discomfort level and their anxiety level and their nervousness level and their inability to communicate. You just have to respect that. Age appropriate teaching and explanations. We talked about child life earlier. They use all sorts of teaching methods. They use pictures, they use dolls, they use they actually have like the IV catheter, and they'll show them how it's like a bendable straw and there's no needle that stays in there, and they can do hands-on stuff with them. And then positive reinforcement. Even if we've had kids that fight and scream until like you wouldn't believe, and you're still telling them, like, you're doing so great, you are so brave, we know this hurts and you're doing so great. Even if you think you're not, please give them just as much positive reinforcement as you can. That just does the best. That's the best for them. Let's see. Oh, and then with these intravenous sites, you need to check them quite often too, because they can't, especially infants, they can't tell you when it hurts, when it's infiltrated, when their arm is swelling, they can't tell you that. So you have to check them very, very often. Okay, adolescent considerations, you need to individualize care with them. Talk to them like they're a person. Don't talk down to them. They don't like that. Provide privacy. They're very, very private at this time in their lives. And so just provide privacy to them as much as you can. Provide emotional support. They may or may not be getting it at home, depending on why they're there. If they're there for like an overdose or some other reason, they might not be getting any type of emotional support at home. So definitely provide that. And then explain it in ways that will be meaningful. What that means, so we had, just to explain that, we had one kid who came in DKA, and he'd come in for problems before, not necessarily a frequent flyer, but we had seen him a couple times, and he kept going into DKA. And this time he had eaten all his Halloween candy, and but he was a type 1 diabetic, was not compliant with his treatments. What's funny is he wanted an insulin pump, but we'll talk about that when we get into diabetics. But anyway, so, and like his doctors would tell him, and the nurses before would tell him, like, hey, like this could cause problems. You can have, when you get older, you can have vision problems. You can have neuropathy. You can have, all these things that this is what happens when you don't control it now. This is what happens in the, in the far future. Well, adolescents don't care about the far future. They don't care about, losing their vision in their 30s or 40s. They don't care about neuropathy when they get older. That's way far away. They don't care about that. So what really got him, though, is when we were explaining it, saying, listen, if you don't take care, if you're not compliant, you can't play basketball this season for your high school. You can't do this right now. And that really opened his eyes. He's like, oh, right now I'll have problems. So explain it in ways that will be meaningful to them. Like in that situation, he didn't care about what was going to happen to him in 20 years. He cared about what was going to happen to him now. So you need to, with adolescents, kind of explain it how it's going to affect them right now, and you'll get a lot better compliance. Okay, so that was chapter 5. I told you they're quick. Geriatric considerations, chapter 6. So these are our older adults. So it's our aging population. So physiologic changes that happen, they have a reduction in total body water. They have a reduction in their body mass. They have a reduction in kidney and liver function. And they have a problem maintaining equilibrium, right? So, considerations, age-related changes in the central nervous system and cardiovascular system. So all these things can change the doses and the medications that they're taking. They have a change in the number of drug receptors. They have changes in the sensitivity of the receptors. Their compensatory responses are decreased. So you have all of these physiological changes that are going to change how the drug affects them. And then as far as monitoring them, we talked about polypharmacy, drug-drug interactions. Like I talked about, they're going to be taking one drug and it's going to cause a side effect. So they're going to take another drug to counteract that side effect. But then that's going to cause a side effect. So sometimes they take another medication to counteract that side effect that's counteracting another side effect of a drug. Anyway, so you get these long lists of medications. And then adherence. There's a lot of reasons why they would be non-compliant or not adhering to taking their medications. Some of it's cognition levels, some of it's, there's just lots of different reasons. So adverse drug events, you have your adverse reactions, medication errors, therapeutic failures. Maybe they're in the toxic level or maybe they fall into the non-therapeutic level, depending on how their body's changing and how the drug dosages change. Adverse drug withdrawal events, and then overdoses. So all of these problems are associated with our older adults taking medications. So adherence, we kind of touched on that just recently. A patient, they might not fully understand why they're taking their medication. Some people found that with that medication reconciliation form, is that some people don't know why they're taking a med. You'll find, depending on where you work with the older population, well, any population really, you'll say, okay, are you still taking Singular? Do you know why you take that? And they'll be like, no, I don't know why I take it. The doctor just gave it to me. Me and you, going into the medical field and being a nurse, we might be appalled at that. Be like, how do you not know? How do you not know what you're taking and why you're taking it? But people just don't. And then non-adherence may cause underdosing or overdosing, depending on what they're taking. Barriers to effective drug use by the older adult, cognition level, stuff like that. Let's see what I have on my notes. And then medication education is extremely important, and not just with not just educating the patient, but educating maybe their significant other or maybe their children, depending on how old they are and what their cognition level is and their ability to take care of themselves. You need to be educating, their caregivers as well as the patient. So here we talk about teaching. With the older adult, you'll want the patient's senses as sharp as possible. If they have hearing aids, put their hearing aids in. If they're wearing glasses, make sure they have their glasses on when you're explaining things and pointing things out, maybe on their medication bottles or stuff like that. So make sure that all their senses are as sharp as possible. Speak in low tones. Usually older people can hear low tones better. Face the patient when speaking. We all know that if we don't quite understand what they're saying, like if we can't understand what they're saying with hearing, we tend to try to read lips and put the two of them together to get what's being said. With the masks, it's been hard for me because there's sometimes I'm like, I can't see what you're saying, I can't hear it, so you got to say it louder. The face mask makes it difficult. You want to limit distractions, turn off the TV, and this goes for any age really. Turn off the television. Tell visitors to leave if they're not the caregivers. Make sure you get their full attention so that they're paying attention. Treat patients with respect. Expect that the patient can learn. Don't treat them like you feel like they're idiots. Use large print and bright colors. There was something else I was going to mention in between there. I can't remember. Came and went. Okay. You want to review all the medications at each visit with them, whether it's a hospital visit, clinic visit, hospice visit, yada, yada, yada. Let's see, instruct patient to take the list of drugs to all health appointments. So I know with my father-in-law, he had a list of all his medications that he's taking, and he takes them with him every time. I think this Vial of Life, I'm assuming it's some kind of a med list. And then just a simple dosing schedule. A lot of these medication dosage plastic containers you can buy, they have like an AM or a PM, and they're just really simple. So if you can get them on, like an AM and PM dosing, then that's what's best for them. What's hard is when you're like, okay, you got to take this one at 8 a.m. and this one at 10:30 a.m. and this one at 1:30 p.m. and this one at 6 p.m. That's when they're going to be confused. I would be confused. And heaven knows I'd miss doses, so you can pretty much expect that they would too. Okay. Yeah. Yeah, Brooke. What's the best is when they don't have the list, but they have all the meds with them. And so you're like, okay, do you know what they're taking? And they're like, yeah, it's all right here. And like they're in like the big gallon size bags and they're all full. And they're like, it's right here. And you're like, oh geez. Yeah, right in the gallon size bag. And then you're like, holy cow, they go through all this, but then you're finding duplicates and you have like half bottles here and half bottles there, and you're just like, oh my gosh, this is a mess. How do you deal with it? So just trying to keep it simple. I think Mark was the one before that was like, make the med list as short as possible. That's right, Kim. Finish your antibiotics. You're going to get, anyway, multiple vials of multiple things. You're going to be like, do you even know which way is up? Like, and then you get those, and I mean, they're not only going to have prescriptions, but they're going to have like their echinacea and their ginkgo biloba and their fish oil and their like all of their herbal and natural bottles too, like their vitamin D and their vitamin C, and you're going to have all those in there too, which are considered meds and you need them on the med list, but it still makes it hard. Consider use of memory aids. After my father-in-law was hospitalized once, he came over on his way home from the hospital. He came over with his big box and he was like, write down everything I need and what time. So I went through all of his meds and I was like, hey, this is when you're taking this one. This is when you're taking this one. So memory aids, writing it down definitely helps. Putting reminders. Some people, not even old people, some even younger people and people with, anyway, all ages, you can set an alarm on your phone, right? Or even on your smartwatches and stuff that'll go off and it'll be like, oh yeah, I got to take my med. So any type of memory aids will work too. So nursing interventions, you want to monitor lab levels, as observe the patient for adverse reactions, especially when multiple drugs are taken. Recognize a change in behavior or a change in confusion. If they're getting worse or getting better. I mean, that either way is good to know. Remind the patient to tell the pharmacist about any over-the-counter stuff that they're taking. That's just not the pharmacist. That's like any doctor they go see. Even if it's a clinic visit or an ER visit, if they're doing like a telehealth even, just like, let them know. Anytime you talk to them and they're giving you new medication or taking you off, just let them know everything that you're on. Be careful with these non-child-proof caps. That is huge. We get so many kids coming in and they're just like, they were at grandma's house and she had these on her dresser, and a lot of older people will just leave their meds out. Like they'll take their pills and like set them on the counter or set them on their nightstand to remember to take them in the morning. And so teaching with that as well, especially if they have grandkids running around, stuff like that, they'll want to keep them up and out of the way. Okay. I have a lot of practice questions, but we're getting a little short on time. So you guys can go through the practice questions. We still have Unit 2 to go through, which I know we're probably not going to get through all of it today. We'll continue at Unit 2 with our Unit 3 next week. But you guys can go through the practice. No, Kim, so this exam, so next week's exam is going to be your math exam. So that's next Wednesday. The Wednesday after that is going to be Unit 1, Unit 2, and Unit 3. So Unit 1 is just this review. Unit 2 is analgesics, and Unit 3 are anti-inflammatories. And then they're all going to be on test 1. So don't feel. Yes, Kim. So exam 1 is going to be your math exam. You have to get 90%. You guys know all this. You have to get 90% to pass the exam. If you don't pass it, you have to come in for a second test. They keep your first. Oh, maybe it's 80. I think it's 80. I think you're right, Brooke. Oh, now I'm second guessing myself. Syllabus says 90. Okay. Oh, Kim, you got this. You got this in the bag. If you guys have any questions, though. So, if you guys have any questions about the math, let me know. Anyway, so yeah, so next week's your math, and then the next week after that is Unit 1, Unit 2, and Unit 3. So you guys can go through these practice questions. If you have any questions about them, like, hey, why is this B and not C? Just shoot me a text or give me a call or a message or whatever, and I can help explain it to you. 60 questions on each exam, except the final is 100. You can expect 60. Yeah. I don't hate you. Just think, if you need to know the stuff so you don't kill a patient. Like, let's be honest. For the math test, there's not a blueprint. It's math. That's right, Brooke. Oh, don't mess it up. And messing up the meds can be messing up the dose too. So, like, if you have a pediatric patient and you're dosing, some kind of med and somehow you calculate it wrong, like, that's bad news. So yeah, and then every pharmacology test, you'll have at least 2 math questions at the end. So at least 2 on my pharmacology test, at least 2 questions are math based. Sometimes there's 3. For the pharmacology test, there are blueprints for them. And I will release those blueprints as the tests come up. There is no blueprint for the math test, though. But you do need to know how to calculate drug dosages. Kim, you got to give yourself more credit. I guarantee you're going to get more than that. Know your conversions, your body mass, how to figure out what is it, BSA, the body square area or something. Conversions, and then it's just, a lot of it's just basic. If you have the right numbers, it's like, if it's 12 milligrams per kilo and he's 10 kilos, then it's 10 times 12 and it's 120. So you know how to convert and times, you can, and you'll have a calculator, or you should be able to use your own, one or the other. I think Canvas has a calculator on there that you can use. So you'll be able to use a calculator, and in nursing, you'll be able to use a calculator too. I think we have three calculators in our med room. So anyway, let me just start a little bit on the analgesics. We're going to have to finish. I'm going to have to finish the analgesics next week because we won't get to all of it, I don't think. They're all pretty much similar. They all pretty much do the same thing, right? Pain relief. Oh, it takes so long. Let me tell you about your learning assignments. So every week in my class, probably like all the other ones, you'll have a learning assignment. It's due by end of today. Today is going to be your drug diversion quiz. And so it's just a little quiz about drug diversion. If you do it, you get the points. If you don't, you don't get the points. That's pretty much how it is. This is not based on how many questions you get right or wrong. I mean, but still go through it. Don't just guess. Because drug diversion is also, you have a few questions on the test about that. So And it's important to know. You don't want to get caught up in it. For the love, this is taking forever. Okay, so analgesics. So pediatric considerations is chapter 5. Geriatric considerations is chapter 6. And then we're going to skip clear to chapter 25. I hope you can still hear me. I can't see you. It's uploading a PowerPoint. We're going to go clear to chapter 25, where it talks about analgesics. There we go. Okay, chapter 25. We'll just quickly go through this. Here's your learning objectives for chapter 25. Real quick, we're going to just talk about the pain terminology. Sorry, I got to get my notes. I forgot. Okay. So pain is subjective. It's based on the patient's perception. It's considered the 5th vital sign. I just have all my notes. Just everybody's different. Everybody feels pain differently. They not necessarily describe it differently, but they can. Their tolerance is different. Redheads, very different with pain. They have a high sensitivity to pain, and they require more anesthetics. That's why a lot of redheads don't like the dentist, because it takes more medication, more anesthesia to numb their pain, and doctors don't necessarily realize that, and so they're actually being under medicated. And it's a genetic thing with redheads. Very interesting. You can read studies on it. Pain threshold. That is the level of stimulus needed to create a painful sensation. Painful sensations, they are, they go through our nerves and stuff. So the threshold is the level of stimulus needed to create a painful sensation. And like, you can kind of I don't know if you guys have ever had like pinching wars. I remember that with my siblings. Like, we would pinch each other, and we'd pinch harder and harder and harder until, then you'd hit that threshold. You'd be like, that hurts. And some people have a higher threshold than others. Kind of interesting. Pain tolerance. Now, pain tolerance is the amount of pain a person can endure without having it interfere with your activity level, your ADLs. So people's pain tolerance changes too. Like, you can get, that pinch might hurt, but you can still do things. You can, if it was a constant pain on your arm or something, you can still do things. Now, pain tolerance is the point where it interferes with stuff like that. So that includes movement, any type of interference with your ADLs. And we have analgesics. We have our opioids or narcotics used to treat severe pain, non-opioids, non-narcotics. Now, I just want to point out here, down here, I didn't do this for unit 1, but I'm going to try to do it for all the other units. This page number right here is the page number in your book where this information is found. Okay, so that's what this little page number right here. That number right there is a slide number. But this is a page number in your book. So maybe that'll help you reference these PowerPoints a little bit better. Okay, then we have our non-opioid or non-narcotics used for mild to moderate pain. The non-opioid group includes over-the-counter pain relievers. And then our nociceptor. We all have nociceptors. Those are our pain receptors in our body. Okay, real quick pathophysiology of pain. I'm sure you guys have done through this before. So we have a tissue injury that activates the nociceptors, right? Our pain receptors. They release chemical mediators. We have a lot of them. This is just 4. We have a lot of chemical mediators that are released. So we have our substance P, prostaglandin, bradykinin, histamine, and a whole bunch of others, and they are released by the body to help deal with this pain. Okay, nerve fibers sensitizes pain receptors. So this is just talking about we have an injury, it goes through our nerve fibers. We have A delta fibers, which are our myelin sheaths. And if you remember back in anatomy and physiology, that information travels faster with the myelin sheaths. We have our C fibers. We have those are the unmyelinated sheaths, so they're slower moving. Our chronic and dull pain goes along those C fibers. Any immediate acute pain will do our A delta fibers. Oh, and then endorphins. Endorphins is also what the body releases to help suppress pain conduction. So it's our body trying to control the pain. Opioids activate the same receptors as endorphins do. So that's how the opioids help with pain. There's a lot of different types of pain. We have acute and chronic. Those are our broad groups. Acute is considered pain less than 3 months. If you have the same pain for more than 3 months, it's now transferred over. Now you have a chronic pain. Okay. So different types of pain. We have cancer pain, somatic pain, superficial pain, vascular pain, visceral pain, neuropathic pain. This is your neuropathy. Electric shock type pain. You've got burning pain, dull. I mean, there's a million different ways to describe the pain. Which reminds me, back to our pediatric considerations. One thing to be mindful of is the way they describe things. Their description of pain is going to be very different, or can be. For example, this morning my daughter got up from bed and we were getting her ready for school, and she was like, "Oh, my hand has bubbles on it. My hand is bubbly. It has bubbles on it, just like my feet did before." And I was like, "What?" This is my 6-year-old. She's like, "My hands are bubbly. My hands have bubbles on them." And I mean, like, first thing I'm looking like, blisters or warts, or like I'm thinking of like, why would she think she has bubbles like her feet? And I'm looking at her feet and I'm like, nothing's wrong with your feet. What do you mean? It turns out that is through some more asking questions and stuff like that. Yes, Brayden, you're right. She was talking about the pins and needles. Like her hands had fallen asleep when she was sleeping, and she like, woke up and so she wasn't describing it as tingling like you and I would, or pins and needles or, something like that. She equated it to bubbles, which is really interesting. So I did want to share that with you before. So when you are dealing, especially with pain, and you're trying to have kids describe something, they can describe it in a whole different way. So you might have to ask a bunch of follow-up questions to try to figure out exactly what they're meaning, because bubbles is not any way I would describe your peripherals falling asleep, but that's how she did. So here's just some pictures of things that would cause pain. Ouch, 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 arthritis pain, headaches, whatever that guy went through looks painful. Okay, so our pain scales. You guys have all been through clinicals once. You've probably seen a million pain scales, and you'll see a million more. This is one that Intermountain uses. We use this a lot on our pediatric floor. It's got a bunch of different things going for it. It's got the smiley faces, or the not so smiley faces. It's got the colors. It's got the words mild, moderate, and severe. It's got numbers, and it's got descriptions under these numbers. I know this is really small and we can't read them, but this is like pain description, like no pain. Here, I can't read them either, but this has descriptions too for those who can read. And so, kids obviously look at the faces and they'll say, "Oh yeah, I feel like this face right here." Or, "No, I'm totally fine. Like, I'm happy, no big deal." So kids usually look at faces. some people look at colors, words, numbers, descriptions. So this has a lot of stuff going for it. It works really well. Here's a few others. We have our Juan Baker faces. This also has faces, numbers. This has descriptions. They're a lot more simple. Like this is like hurts a little bit, hurts a little more, hurts a lot more, like hurts a whole lot. So sometimes they do that. And with kids, I like to say, does it hurt a little? Does it hurt a lot? And then depending on what they say, then, try to pinpoint it more. Here, this one has colors too, numbers, one word descriptions, and then, sentences that can help. And then this one's a FLAC scale. For those who work with babies and toddlers, anybody who can't speak or communicate, maybe in the ICU, you'll do a FLAC scale. So they call it FLAC for face, legs, activity, cry, and consolability. And then you give them numbers, and this has descriptions like, how does the face look? Is there any emotion with the face? Are they grimacing? Are they, stuff like that. And so each number has a description. And so based on how the patient is acting, this is how you would rate their pain. Say, oh, well, they have a 0 for face, a 1 for legs, a 1 for activity, a 0 for cry, a 2 for consolability. So their pain level is a 4. I think I added that right. And so this is for babies, toddlers, and anybody who can't communicate their pain, probably in the ICU stuff. So it bases their pain level on how they're acting. Now, this is not appropriate to rate somebody like you or me who is sleeping. You put a FLAC scale in for an adult who is sleeping, there's a chance you could get some feedback on that. It is somewhat frowned upon to do a pain scale in the middle of the night, a FLAC scale on somebody who is sleeping. They require you to wake them up and ask them their pain scale. So. Okay, under treatment of pain, that is huge. And like I talked about with the redheads, with their anesthesia, local and general, they just require more. And so, under treatment of pain is huge. Let's see. What are some reasons for under treatment of pain? You guys think of any reasons why somebody would be undertreated? Anyone? Bueller? Just kidding. Okay, more addiction. Maybe their pain tolerance is too high, right? They come in for surgery, the doctor gives them one Lortab and they're addicted, and so they require a higher dose, but they're not getting it. So that decline meds, right? Some people think they can just handle the pain. Underreported, don't want to pay for care, right? Increased care. They think, oh, they're afraid if I go in for this knee pain, it might end up in surgery, and I just can't do that right now, right? Avoid addiction. That's right. Some people, you'll find a lot of recovering addicts. They'll, if they're smart, they'll just stay away from it. And some of them just have to deal with the pain because they can't have anything strong enough to take care of it. Denies how much pain they're really in. Yeah. So some of it can be fear, and a lot of different fear, like fear that the nurses will believe me or the doctors will believe me that I'm in this much pain. Fear that, they're going to be a burden. You'll see that with a lot of older people. They'll be like, oh, I was in pain all day. Thank you for giving this. You're like, why didn't you tell me? And they're like, oh, I just didn't want to bother you. And it's just like, are you kidding me? Right, Megan, you're right. If it's a child, they might feel like, oh, if I say, that I'm in pain, like something bad's going to happen, right? Or they have an inability to describe the pain. If you're like, you get that a lot with kids. They'll say, it hurts. You're like, what does it feel like? And they'll be like, I don't know. It hurts. And so sometimes not knowing what kind of pain it is, trying to find a medication that helps with that pain is hard. Let's see, their attitude with pain. A lot of older people feel like, pain. It's a natural way of aging. Like I expect a lot of pain when I age. That's not necessarily, that's somewhat of a myth. It shouldn't be painful to age. Arthritis is a little different, but in general, like just the fact of aging, it should not be painful. So yeah, their sociocultural background, right? Sometimes they think it's, manly to put up with the pain, or, it's not appropriate to take pain medications, stuff like that. So there's a lot of reasons why we have an undertreatment of pain. So here's our opioids. Opioids are going to be prescription and hospital meds only. Non-opioids, over the counter. They can also be prescription as well. Okay. So, oh yeah, sorry. Let's go back to this real quick. I didn't touch on this. The effects of unrelieved pain. What kind of things can happen when you have unrelieved pain? Right. The body has a hard time healing. Crying, absolutely. Get dehydrated that way pretty easily. Emotional damage. Vital sign changes. Right. Increased heart rate, increased respiratory rate, increased blood pressure. Right? Yeah. Heart rate. You can get some urine retention, fluid overload, electrolyte imbalance. Like it's a whole body changer. You can get glucose intolerance, increased risk for infection, weakness, confusion, and then increased healthcare costs. For example, that knee pain that we mentioned before, maybe if this person would have gone in right away, it would have been like, oh, let's get you some physical therapy, let's get you an anti-inflammatory, maybe a brace, and you're set to go. But no, she waited 6 months. Now the pain is worse. Now they go in, she has to have an MRI, she's got to have an x-ray, and now they're doing a scope. So, so under treatment of pain and not figuring out what it is at first can definitely lead to increased medical costs, because now she is looking at surgery where before it wasn't, necessarily that bad. So yeah, and with Amy saying the body can't heal, that's absolutely correct. The body heals better, the body heals faster when it's not in pain, or when the pain is reduced, because that's less stress on the body that it has to worry about, so it can focus more on healing. So if you're ever on a surgical floor or anything like that, and you have people who are like, yeah, I don't know if I want to take the pain meds, like, no, it's important. We need to get this pain under control, because your body will heal faster when it's out of pain or has decreased pain. Okay, so these are non-pharmacological therapies to treat pain. Okay, they're usually used in conjunction with drug therapy, not necessarily in place of it. Okay, so we want to elevate the extremity, or the part of the body that is affected, right? Ice packs, heating pads, sometimes you can alternate back and forth. Position changes, massages, mediation or distraction, and then this controlled nausea. It's really interesting. Pain causes nausea, nausea causes pain. It's this vicious circle. So if you can control the nausea, you have a lot better control on the pain, and vice versa. If you control the pain, have a lot of control A lot more control in the nausea, especially in surgical situations. Okay, let's just stop there. And then we'll talk about non-opioid and opioid analgesics next week. Does that sound good? I hope so, because we don't have much more time. And I don't want to like stop in the middle of something. So we'll just stop here. We'll continue next week. You guys have been a great audience. Thank you very much. Megan, it's not going to be the first. It's not going to be the last time that you're going to feel like that. It's a lot of information. But if you take it a little bit at a time, like study a little bit. There's a bill for that. If you study a little bit every day, I promise you it won't be bad. If you wait till the very last minute, like I know you guys have tests on Mondays, it looks like. And I understand you're studying for that test too through the weekend, but like you're going to retain so much more if you just study everything like on a daily basis. So please don't try to cram. It's not going to be your friend. Oh yeah, and the health assessment. We'll see you tomorrow and Friday. I know you guys are all split up. So just try to study a little bit of pharmacology every day. And like I said, do those flashcards in a way that's going to help you. Okay, if you have to draw pictures, do it.
Hey, Corby.
Yeah.
Are you going to open up the sign-ups for the thing? I can't remember what it's called, but that thing.
Yes. Yes, I'll do that at 2:20. How's that? I'll make that available at 2:20 and the diversion quiz. I'll do both those at 2:20, so they'll be available.
Sounds
and
excellent.
Then,
thank you.
Yep, and then you guys should be able to sign up and do your quiz by the end of the day, and then start studying for your health assessment and pharmacology. Okay, and then I'm going to just like say it every single time. If you guys have any questions, please don't hesitate to reach out to me. Okay? I don't want any, I don't know. I just don't want you guys to like sit in a sea of wonder and feel like you're just aimlessly floating around. Okay. All right. You guys have a good week and-ish in a dark room rocking back and forth. We'll see you guys throughout the day tomorrow and Friday. And have a good rest of the day. Thanks.